This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I have the pleasure of interviewing Dr. Dean Watson to discuss the role of cervical afferents in primary headache and the Watson headache approach. Dr. Watson has been a PT since 1976, specializing in the treatment of headaches and migraines. Dean's Ph.D. investigated the role of cervical afferents in migraine, which for the first time demonstrated a manual cervical intervention, the Watson headache approach, improving the underlying disorder in migraine. Since 1990, Dean has treated headache and migraine conditions exclusively. In our discussion today, you are going to learn about primary and secondary headaches and their presentations, how to identify red flags associated with headaches, the role of cervical afferents in headache and migraine, and the Watson headache approach, how to desensitize, sensitize brain streams, and much more. So if you find this information valuable, I encourage you to subscribe to our channel, click on the notification bell to stay updated, give us a thumbs up, and share with other clinicians you think might benefit from this conversation. Thank you for tuning in, and I hope you enjoyed the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Systems for PT, the Do Anything, Anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today.
Looking for the highest quality equipment for your clinic? Turn to Fitter First. Our wobble, rocker, and slant boards are all assembled in North America to meet the demands of a busy professional clinic. Designed to adjust in seconds and made from the highest quality materials. Get the best Canadian-made rehab and balance products for your clinic. Order online for your clinic or for your clients. Ground shipping anywhere in North America. Visit fitterone.com. That's FITTER, the numeral 1.com.
Hi, Dr. Watson. Welcome to PT Pro Talk. How are you today?
I'm good, thank you, Mariana, and thank you very much for the invitation.
I'm excited to have you here and start talking about headache and ask you everything about your method. So let's get started talking a little bit about yourself and your career.
Well, Mariana, I think I'd like to start at the end, so explain why I'm standing here talking to you about headache and migraine. So since 1991, I have treated headache and migraine-related conditions exclusively. So I now have over 40,000 hours of clinical experience with over 10,000 patients. Now, it's not the volume of experience that's particularly important here, it's the nature of the experience. And the nature of the experience is one in which over 90% of these patients were self-referred, which means I've got to see, as a physiotherapist, many headache and migraine conditions that we're taught as physiotherapists, physical therapists, we have no role to play. And my perspective as a result of my clinical experience is that cervical afferents are significantly involved in the primary headache group. Now, in the primary headache types. So we'll come to this in a moment. But my journey started in 1976. And boy, was I lucky. When I started my undergraduate program, I was fortunate enough that Jeff Maitland was heavily involved in that program. Now, Jeff Maitland was an icon here in Australia back in the 1970s, 80s, 90s, actually 1950s, 60s, 70s and 80s. And for those of you who are familiar with the Maitland approach, you'll see that when we get to talking about the approach that I've developed, it is not the same as Maitland, Jeff, but I was lucky enough, as I say, for him to be involved in my undergraduate career. And then I did a postgraduate diploma in Advanced Manipulative Therapy, and I was one of 9 students. There were 6 international students, and this was held here in Adelaide, South Australia, and this was 12 months full-time. And so, once again, Jeff was the founder of this course, and so he was heavily involved. So I have a very heavily influenced Maitland background, but as I said earlier, the approach is not the same as Maitland. But what I did learn from Jeff was that he was a master clinician, a master communicator. To actually see him with patients, it was just amazing. So what I learned from Jeff was the art of doing a subjective examination. He would always sit just a little bit below the patient, and he'd be quite close to the patient, and would be continually paraphrasing their answers and coming back to make sure that, and by doing that, repeating to some extent what they're saying, of course the patient gets, they can see that you're really listening. And so, and subjective examination in headache is arguably more important than in any other MSK condition, because in other MSK conditions we have objective signs that we can tell us whether we're getting somewhere or not. Whereas headache, there's a significant reliance on the subjective features. So the history is king here in headache medicine. So I learnt that from Jeff, and just the palpation. We had just 12 months full time learning palpation. And so this was an amazing year for me. It was probably the most instrumental year, 12 months of my professional career. Anyway, after that, in 1985, had I not had a mortgage to pay, I would have left physiotherapy. I only came to realise that subsequently why I would have left physiotherapy. But it was because I wasn't making the difference I thought I would. I thought, you graduate, you think, you come out and you're going to help all these patients. You think, wrong. So I'm thinking, but back then you didn't change professions quite so readily, or unfortunately forced to do in some circumstances. So I thought to myself, what was it that I could do to just reinvigorate my passion for physiotherapy? I mean, you do physiotherapy, physical therapy to make a difference. And as I said, I thought I wasn't making a difference. Trying to be really good at everything, all the conditions that we're faced with as physiotherapists, it's really hard. So anyway, I decided, I'm not quite sure why I chose to look at this, but I looked at natural head posture in cervicogenic headache patients, and also the performance of the deep neck flexors. And so that was back in 1985. So I started this master's degree by research, and I completed that in 89, 90, and the results of that created such a lot of interest in the community and professional community and the public that I decided from that moment on I would just treat headache and migraine. So I set up the headache clinic, and sort of the rest is history. So along the way, I've developed this approach which just looks at the upper cervical spine, and this is all I do. So it's very much a manual approach. So I've been doing this, and then I think back in 2014, I decided that I thought, well, what is it that we're doing here? Because my technique was about sustaining. So I use my thumbs to assess how well one vertebra moves in relation to the other. But I don't oscillate. This is about sustaining. And I started sustaining for all the wrong reasons. I thought what you needed to achieve was creep in the soft tissues. But of course, we've come to learn that this is not the reason why. Anyway, I continued to sustain. And what I was finding was that I could reproduce the pain of headache, the typical head pain, and as I sustained the technique, we got resolution. Patients reported their pain was just getting less as I sustained the technique. So I was doing this, what I call reproduction and resolution of headache, back in the early 1990s. And so along the way, I kept on thinking to myself, now what is it that I could, what effect are we having here? And so that I started looking at this research question, if you like. And a seminal moment came along at early 2000s. I had this patient come in and he said, Dean, I don't have my migraine at the moment, but I'm always tended to touch right here, around the hairline, or where the hairline used to be for some of us. Anyway, he touched there. He said, that's been there for 10 years. He said, it's always tended to touch, even outside of a migraine. So allodynia, okay, central sensitization. So I went through my usual practice and went into reproduce the pain of headache, got resolution, and I did that several times, which is part of the process. It's 3, 4, 5 sustained holds, and with that you get the extent of the reproduction is less, and it eases more quickly, more expeditiously. And after the 5th hold, I said, well, now can you sit up, and now I want you to touch your head again. And he goes, my God, what have you done? It's gone. So the allodynia went literally within a matter of minutes, and my PhD was gone. My PhD was born. So I then did my PhD where I looked at, I used a nociceptive blink reflex, which is a trigeminofacial brainstem reflex, which measures the activity or trigeminal processing, trigeminal nociception in the trigeminocervical complex. And what we know, what the reflex has shown us, is that people with migraine are sensitized interictically, in other words, outside of a migraine attack. So I did the reproduction and resolution with these migraine patients, and we found that this reproduction and resolution ameliorated the nociceptive blink reflex. We had a desensitizing effect. And this is the first time to my knowledge that a cervical intervention has been shown to affect the very core of the migraine process. And indeed, we can extrapolate what we know about migraine to the other primary headache types, tension headache and cluster headache, because migraine is a phenotype of primary headache. So here we are now doing a cervical intervention, and we are demonstrating desensitization of the trigeminocervical complex. And it is widely accepted that sensitization of the brainstem, the trigeminocervical complex, is the underlying disorder. It is crucial in migraine and also cluster headache, menstrual migraine, and tension headache. So the other primary headache types. So that was my PhD, and for me it was a bit yes. So now I took a deep breath and I thought, wow, okay, that was, went through that amazing experience doing the PhD with a fantastic guy here in Perth, in Western Australia, Peter Drummond, a neuropsychologist, and he was amazing. But yeah, so that's my journey, Mariana, and yeah.
That's quite a journey. You just said so much. I have so many questions. Okay. So let's start from the beginning. Let's talk about the different types of headaches, primary, secondary.
So headaches are divided into two types. So you've got your primary headache types and your secondary headache types. Now, secondary headaches are those headaches that are secondary to a known lesion, a recognised pathophysiology. Now, of course, in that secondary group is cervicogenic headache because it's secondary to a cervical lesion or a recognised pathophysiological process. And so, but more often than not, when the term secondary headache is used in medicine, it is referring to an underlying disease process or medical condition. But we shouldn't forget that cervicogenic headache, along with headache as a result of TMD, they're classified secondary headaches. So secondary headaches are those headaches with a known cause, whereas primary headaches are those headaches in which the mechanism, the underlying pathophysiology is unknown. The cause, indeed, that's what defines primary headache. Now, in the primary headache group, there are three main families. You've got your tension headache group, your migraine group, and your cluster headache group.
Okay, so the tension headaches are considered primary. I thought that they were, okay. And they are caused by muscle tension?
No. For 150 years, it was assumed, and again, it's an assumption, because of the throbbing nature of migraine, that migraine was a vascular headache. Well, that's been put to bed 20 years ago, research. But likewise with tension headache, there was an assumption that tension headache was a result of increased tone in the muscles of the scalp and forehead, and we know simply that that's not the case. So, and even though the cause is unknown in tension headache, the medical model of headache recognises that the underlying disorder in tension headache is not increased muscle tone.
And do you know the cause? Do we
No,
know the
we don't know
cause?
the cause. There's a lot of research going on around tension headache. Look, I really, what frustrates me about this whole game, if you like, you've got the medical model of headache with this very cumbersome, unwieldy classification system. And what I come up against all the time is that, because what I'm about to say to you, and we'll get on to this, is that cervical afferents can be the key driver in the primary headache group. And of course, people say, no, Dean, you can't. It doesn't happen. Well, hang on, how can you tell me cervical afferents are not playing a role if you don't know what the cause of primary headache? That just doesn't make sense.
Doesn't make sense, yeah.
Yeah, okay.
And to make it a little clear, to differentiate, what would be the characteristics that would differentiate the tension type headache, the migraine, and the cluster?
Look, I think essentially tension headache is a bilateral headache. The quality of the pain is a squeezing, a pressure, a heaviness, as though my head feels like it's in a vice. Very few associated features like nausea. You don't get that, although a small percentage of tension headache patients report some nausea and occasionally some vomiting and some sensitivity to light. But generally, it's considered to be a featureless headache. Okay. The intensity sits around a 5 out of 10. So whereas migraine is typically a unilateral headache, so that's the meaning of migraine, it's unilateral head pain. But you do see bilateral cases, of course. But the quality of the pain is throbbing. Any headache that is throbbing in nature attracts a diagnosis of migraine. And of course, you have many associated features typically with migraine: nausea, vomiting, sensitivity to light and sound, etc. And then you have your cluster headaches. Now, the cluster headache is a member of the trigeminal autonomic cephalalgias. So the trigeminal autonomic cephalalgias, the TACs, it's a mouthful, TACs. And in this family of TACs is cluster headache, chronic paroxysmal hemicrania, and a condition called SUNCT, which is an acronym. But these headaches, they're all in the same family, if you like, because they present in a very similar way with subtle variations. And the most common headache in the trigeminal autonomic cephalalgias is the cluster headache. So typically we talk about that. It is characterised by sharp stabbing pain. The pain is severe. It's awful. Look, cluster headache is often referred to as suicide headache because, people contemplate it. And what happens is that the headache starts in this short, sharp stabbing bursts of pain, which last maybe 10, 15 minutes, up to 180 minutes. And this may occur 6, 7, 8 times a day. And it goes on for a defined period of time, like it might go on for 2 weeks, day and night. And then they might have a break for a month. Or it could go on for 3 months and they've got a break for 9 months. Or it could go on for 6 months and they've got a break for 2 years. But this goes on throughout their life in this same pattern. And along with this, so this cyclical nature, it's relatively easy and the nature of the pain is relatively easy to identify cluster headache, but also because of the associated features. If I've got right-sided cluster headache, my right eye will be watering. There'll be lacrimation. The white in my right eye will be red as a result of dilatation of the conjunctival vessels, and my right nostril will be stuffed or blocked, and maybe even a thin mucus discharge. For example, Mariana, I've just seen a patient, and this guy, at the age of 18, 12 years ago, he awoke at 2 a.m. in the morning, and he had these short, sharp stabbing bursts of pain. Now, this went on until 9 a.m. And he would have 7 to 8 episodes lasting 30 or 40 minutes of this pain, unbearable pain. People bash their head against the wall to try and get rid of the pain. It really is awful. And this went on and on. And then, he had, many investigations and treatments, medications, oxygen therapy, a whole lot of things. And then in 2018, so this would last a week, and it started the 20th of every month. He called it his menstruation. Boy, this guy's got a sense of humour. He does, despite this. In 2018, it went from lasting a week, from 2 a.m. to 9 a.m. every day. It lasted 2 weeks. Now it's gone from 1 week to 2 weeks. And he in 2019, he attempted suicide. And that's, it gets pretty hot in the kitchen when you are dealing with headache. I can tell you. But anyway, I've just started treating him, and I'm really, because everything I felt in his neck, it just fits the picture of cervicogenic involvement here. And I've only seen him on 2 occasions, and I'm seeing him again now. The 20th, we're coming up to the 20th of the month, and it's D-Day. We'll be monitoring very closely because I expect to make a change in this.
That's so interesting. And why do you think that is so cyclical?
Look, I don't know, and no one knows. Marion, it's a great question. I don't know. And there are many things we don't know about primary headache. But I just treat what I find. Well, I look in the upper neck, and I know, having seen over 10,000 patients, there is a typical pattern of musculoskeletal misbehaviour. And it's all to do with rotation of C2. And look, none of us are symmetrical. We all have asymptomatic asymmetries. So C2 is going to be deviated. But I just know in the vast majority of cases, the spinous process of C2 will be deviated to the side of headache or increased frequency if you've got alternating headache. So headache, unilateral headache that side shifts between episodes or within the same episode. But you've got to determine, so there's a 50% chance that C2 is going to be deviated to the side of headache anyway. But along with that, being able to reproduce the pain of headache and get resolution, that for me is the most powerful clinical tool we have of demonstrating cervical relevancy. And we might come on to that later as to why I think that. But I'm sorry, I think I'm getting away from you a little bit there.
No, and on the secondary group, the cervicogenic headaches, how do they present?
I hate the term cervicogenic headache. It actually boxes cervical afferents.
It's confusing because you said that the other ones are like cervicogenic. So what is the real cervicogenic group?
Well, if you listen to or you look at the classification system, the medical classification system for cervicogenic headache, it looks something. Now, I find this rather interesting too. Here we have diagnostic criteria for cervicogenic headache, a musculoskeletal event. These diagnostic criteria have been established by those not experienced in manual medicine. That doesn't make sense, Mariana. Just does not make sense. Be that as it may, supposedly cervicogenic headache is unilateral and side-locked. In other words, it's always on the same side. Of course it is. It can be. But a headache that swaps sides alternating headache is a musculoskeletal event. But this erroneous diagnostic criterion, which says cervicogenic headache is side-locked, it's a travesty of justice. It denies many people, because 80% of people with migraine, their headaches alternate, they swap sides. This is a sign of it's a musculoskeletal event. And so this alone, I think, it's so frustrating, because I can change the side of someone's headache like that. Come in with the right side of the headache, I can do something at C2-3, they sit up and the headache, they say, Dean, the headache's gone to the other side. And likewise, C2's rotated accordingly too. And it's all to do with that. So essentially it is, you can have nausea and vomiting with cervicogenic headache. It's a bit like, this side lock unilaterality is a big thing here. Being able to reproduce the pain of headache is a key diagnostic criterion. Now, I think you can be really suspicious if you do that, but it doesn't confirm relevancy. For me, relevancy means reproduction and resolution as you sustain the technique. And I can go into that later on. I think we'll get to central sensitization later, Mariana. But so the reproduction of headache is a key diagnostic criterion. But for me, it's not enough. And also, the big thing here for the medical model is an appropriate response to an anaesthetic block. So the idea is you have to have something like 90% reduction of head pain with an anaesthetic block. Now, best practice is you go to C2-3 first, and that's appropriate. That is the foundation of headache. But what happens if you don't get, you've got to have something like 90% reduction. What happens if you don't get 90% reduction? So let's say, for example, there's 40%, 50% reduction after targeting C2-3. Best practice says you go to the segment below and the segment above. So C3-4, okay. Does the trigeminal cervical nucleus extend that far down? No, probably not. The chances of getting any more resolution from C3-4 is minimal. And then you go to C1-2. And for me, C1-2 is rarely involved in headache. Now, I know that probably contradicts a lot of what people are saying, and I get that. And I think this all comes about as a result of the flexion rotation test. And whilst I think the flexion rotation test is a good sign of upper cervical dysfunction, it does not, for me, tell me. This is a comparative sign. You've got restriction. So now the assumption, and it is an assumption, that the headache is coming from the 1-2 segment. Sure, the flexion rotation test does emphasise movement at the 1-2 segment, but you're also stressing O1. You're also stressing C2-3 when you're doing this. So, and research shows, and this is in accordance with my clinical experience, is that probably 5%, the prevalence of headache from C1-2 is about 5%. My experience is you need to go to C0, C1. C0, C1 and C2-3 are in love. They are often, in 80% of cases, you'll get reproduction, referral and resolution from C2-3 and C0, C1. But going to C0, C1 with a needle is like tiger country. Not a lot of people do that. So, are we going to get significant resolution following anaesthetic block under those circumstances? The other thing about this is that there's no way you can block information from the C2-3 segment, C2-3 disc. You can't. And we know the C2-3 disc can be responsible for headache. So, look, the anaesthetic blocks are a powerful ally, but they're not the be-all and end-all. But the medical model of headache relies very heavily on the appropriate response to an anaesthetic block. But I'm sorry, it's wanting, frankly. Cervicogenic headache has to jump through so many hoops. No wonder it's considered to be a very rare form of headache, and we all know, and your listeners know, we all know it's far more prevalent than 4% or even 16%. It's as prevalent as migraine and tension headache, if not more. So I don't like this term cervicogenic headache. I'll come back to that because it does box cervical afferents to this condition called cervicogenic headache. I'm about now, why don't we consider whether or not cervical afferents play a role in sensitization of the trigeminocervical complex? We know the trigeminocervical complex is sensitized in those with migraine, cluster headache, tension headache, to a lesser degree, tension headache. Now, think about this. It's the trigeminocervical complex. Come on. Cervical afferents are they're more than in the front row here. They're in the box seat to sensitise the trigeminocervical complex. But it is disregarded. It's not considered.
And why do you think that?
Well, because I think the medical model of headache, it's driven by, it's owned by neurologists. And their perspective is head. But that more and more attention is being drawn to now we've got more, I'll say, manual therapists, around the world, looking at the role of the upper cervical spine in primary headache. And this is exciting. And some people are looking at investigating reproduction and resolution of head pain, which I started in the early 1990s, and using that in their research and the like, which is really exciting. I'm really pleased to see that that's happening. So look, essentially, I'm not here to, the medical model is wanting, and there are people within the medical model who are of this opinion. It's not kept up with current research. It considers all the primary headache types as being distinct entities with different pathophysiologies. But the debate has gone on for decades as to whether or not they're just different expressions of the same pathophysiological process. In other words, they're all apples, just with different coloured skins. And that's my clinical experience, and that's what the research is showing us. For me, Mariana, the optimal question is, what is sensitising the trigeminocervical complex? That, to me, is the optimal. I put a diagnosis off to one side. It's not important for me. A diagnosis is just based on a set of signs and symptoms. It doesn't tell us what we're dealing with.
Mm-hmm. Mm-hmm. And just going back to what you said before, why do you feel C0, C1, and C2, C3 are the most common affected?
Look, I think they have got the 1-2 segment is a very mobile segment, isn't it? 1-2 segment. C2-3 is the least mobile segment of, along with C6-7, C7-T1 in the cervical spine. Now C0, C1, fair bit of movement in the sagittal plane, but rotation, minimal movement. So I often wonder whether it's this relative, normally small ranges of movement that when it comes to trauma, also in terms of sustained postures. What's going to, if we're sitting like this all the time, that the lax capture around 1-2 is not likely to be affected significantly, but, the segments being in these sustained postures for long periods of time, because their relative lack of mobility. And look, I talk about C2-3 as, really, I look at C2-3 as being a transitional segment. When you think about it, above C2-3 is the most mobile part of the cervical spine, and all of a sudden it comes up against the most immobile part of the cervical spine. That poor old C2-3 segment has a fair bit to deal with, and when you look at it closely, it is structured differently. The facet joints are structured differently. They're medially inclined. They are very obliquely oriented. For a reason, it's a saddle. I call it a saddle for the upper cervical spine. And the movement, and two, research shows that certainly it makes sense that the kinematics above C2 relies very heavily on C2-3, kinematics 2. So there's a real interdependency here.
Yeah, it makes sense. And on the secondary headaches that are with the known causes, what would be the known causes for cervicogenic headache on that classification? Just a few examples to make it a little more clear.
Known causes for cervicogenic headache?
Yeah, like a whiplash, something like that?
Yeah, certainly trauma, but postural.
Tumor?
No. Tumour. Tumour won't give you cervicogenic headache, but So the signs and symptoms, the reasons for cervicogenic headache developing are where you've got sustained postures, trauma, and look, micro trauma, and people who are on assembly lines with their head down 8 hours a day in sustained flexion, and we know the weight of the head, 5 kilograms, head neutral on the neck, 5 kilograms, but every 10 degrees or so it goes up by 10 kilograms. In the end, it's quoted as being 25 kilograms. Likewise, that's flexion, but this forward head poking chin posture, every few centimetres, that increased from 5 kilograms to 10 kilograms and so on. So just posture is very important too. So it can be, really innocuous, like, well, don't know why it's come about. But it's just this Western world we live in, I think, phones, postures. Whereas you've got the medication overuse headache, which is a controversial diagnosis, is the most common of the secondary headaches. So it's secondary to this medication overuse, pathophysiology, whatever that is.
Okay.
But it's a very controversial diagnosis. The jury is still out. But then, of course, you've got your tumours, you've got your cranial vasculitis, life-threatening diseases, conditions, etc. And it's the history here that's really important. So these conditions are going to escalate pretty quickly within 3 months, and there are various red flags that I won't go into necessarily today, but these are. Interestingly, though, when you're dealing with primary headache and secondary headache, they share symptoms, so the symptom expression can be very similar, like someone with a tumour. As well as migraine, their symptoms can present in a very similar way. The difference is the history, and history is key in headache medicine when it comes to sorting out your red flags.
And what would be some red flags that would make you think about referring the patient back to the doctor?
Oh, look, most migraine starts in your teen years, and 20 to 30 years of age, etc. If someone over 50 develops a migrainous headache for the first time in their life for no reason, that is a red flag. Migraines don't start in your 50s. So nausea, vomiting, etc. Medical investigation is required. But likewise, if you've got someone that's starting with headache that is, in the 30s, and there's no reason for it, and it's getting worse, and all this is happening within 3 months, and with nausea and vomiting, then that needs to be investigated. Or someone who has a tension-type presentation for 15 years, they've got a long established history, and all of a sudden it changes. So these changes need to be within the last 3 months, within the 3 months. The 3 months seem to be fairly critical here. A headache that's stable for longer than 3 months is considered to be benign in the primary headache group. But if someone has a tension headache presentation for 12, 15 years or so, and all of a sudden they start vomiting, of course vomiting is not a feature of tension headache, there is something like a whopping 90% chance that is a result of the development of intracranial metastases. So that's a real warning sign here. Headaches that wake people first thing in the morning, and they've got to get up and move around. This is a classic sign too. You've got to be, that's a sign of increased intracranial pressure. Now, it's not the tumours that actually lead to the pain. It's when the tumours get large enough to change intracranial pressure. That's the issue here. So there are just a few things.
Okay. And going to the history, you mentioned so much that the history is king. What would be things that you'd see in the history that would lead you to think that it's cervicogenic?
Well, firstly, let's go backward. I'm now looking to see that it's not cervicogenic. My experience, when you think about...
You're trying to prove that's not cervicogenic.
When you think about it, I said over 80% of people with migraine, it's unilateral and it alternates. Alternating headache is a musculoskeletal event. So, for me, what am I saying? Well, that says Dean saying, well, okay, over 80% of migraine is musculoskeletal. Well, that doesn't go down very well. But that's my experience. And so I am looking at, firstly, I need to rule out the red flags. I need to rule out, the underlying disease processes or medical conditions first. That's what I aim to do. But the chances are, look, the average length of history of patients by the time they get to me is 15 years. So 20 years, 25 years, 30 years. It's not uncommon to see someone with a 30, 40-year history of headache. So that means, Mariana, that they have been medically screened. So that all the red flag stuff has been done. They've had head scans, they've had a neurological examination, et cetera, et cetera. So all this has been done. But nevertheless, you still need, if you've got someone with a long history, you need to establish that they're in the last 6 months that things have remained the same. You always look for a sudden change in the presentation, particularly if the patient's over 50 years of age, and that becomes a red flag. So having done that, then I'm going for it. As I said before, Mariana, I put the diagnosis off to one side, and I'm looking for relevant cervical dysfunction.
And then what do? You do like range of motion and do manual tests?
No, I don't do range of motion because it doesn't give me any information. We can look at the research and, range of motion's good or, range of motion. Look, the research is equivocal when it comes to headache. I don't do PIVMs, passive physiological invertible movements, because all that does is it gives me an idea of hypomobility and once again, that leads to a comparable sign. When I say comparable sign, I mean, okay, something's stiff here and it's locally tender. You assume that the headache is coming from that. No, that's not enough. Symptom reproduction is what I'm looking for here. And you're more likely to get that when you're doing PAVMs, passive accessory invertible movement. And so that's where I go in. Straight away, I don't necessarily look, if someone says to me, Dan, I get a headache when I turn to the left, well, of course I'm going to look at that, but that's very rare. You don't often hear that.
Because you don't know if that tension is related to headache unless you reproduce it, right? So you're just trying to make sure you're looking at the right thing.
Yeah. And where is that? And likewise, if they're a bit stiff, where is that loss of range? Is it 4-5?
Yeah.
And likewise. So look, I think it's the approach I've developed relies very heavily on skill palpation.
Okay.
And that's it. And there's a series of techniques that I can use where I can stress O1 without 1-2, 1-2 without O1, 2-3 without 1-2. So I know exactly which segment I'm stressing. And I don't use high velocity thrust techniques. This is not part of what I do. I can make a comment about that later. Yes, so it's very much about PAVMs and looking for reproduction. But I don't need to reproduce the pain of headache if someone says to me, Dean, because I say to people, do you think your neck's involved here? And they go, oh yeah, of course I do. I know it's my neck. I don't need to do that. Or if they come in with headache, and I prefer to see them without a headache when they present for their appointment, but if they come in with headache and I put them into retraction and it changed their headache, you've demonstrated cervical relevancy.
Uh-huh.
I remember someone bursting into tears when I did that. 10 years of migraine, thousands of dollars on the triptans, and came in with headache and I did this and I went away. She said, is that it? I said, yep. And she just, so you don't need to reproduce the pain of headache in that situation either. But there are many people who say, no, Dean, I've got no idea where my headache or migraine is coming from. Okay. And you'll do this in over 90% of patients, irrespective of the diagnosis. So, for me, this is going to sound, well, I'll say it anyway, because that's where I come from. My 40,000 hours of experience tells me this. For me, every headache is cervicogenic until proven otherwise.
Good. Okay.
So we're talking about cervicogenic headache. Now we're talking about the role of cervical afferents in sensitization of the trigeminal cervical complex in primary headaches.
Okay. So what is your approach? What is the Watson headache approach?
Look, it's summarise it. It's very much about. I recognised a common pattern of musculoskeletal misbehaviour in the early 1990s, and it's as a result of rotation of C2. So, let me just backtrack. I've talked about alternating headache being a musculoskeletal event. Now, for me, alternating headache is a C2-3 equivalent of an alternating lumbar list. Okay? So, I don't know how many of you have seen an alternating lumbar list. Alternating lumbar list. So I've got back pain on the right, I'm leaning off to the left. Back pain on the left, leaning off to the right. And what's the underlying issue here? Lumbar disc. So for me, my hypothesis is that rotation of C2, because the spinous process of C2 will be deviated to the side of headache in 95% of cases. So I'm saying that what we have here, and I'm not talking about a disc bulge at 2-3, I'm just talking about an asymmetrical distribution of pressure in the C2-3 disc. And it doesn't take too much to put a bit of tension on the posterior annulus of cervical disc, because the annulus posteriorly of cervical disc is very thin. Unlike the lumbar discs, it's the same all the way around. So now we have tension in the left, okay, in the left posterolateral corner of the disc. Tension in the annulus. And of course, the sinovertebral nerve innervates the posterior annulus. Okay, well, Houston, we got a problem. And the body comes in to protect this, and it brings in spasm of a muscle that runs from C1 to C2, inferior obliquus capitis. It is the most sensitive muscle in the body, something like 240 muscle spindles per gram of muscle tissue. It doesn't traverse the C2-3 segment, I get that, but it's close enough to react to it and goes into spasm. By virtue of its attachment to C1 and C2, it rotates C1 in relation to the occiput. It rotates C2 in relation to C1, and it rotates C2 on 3. This powerful mechanism stresses all three potential head pain referring segments. And my hypothesis is that it's driven by an asymmetrical distribution of pressure in the disc. Now, when I say this, people say, Dean, you can't extrapolate what happens with lumbar discs to cervical discs. They're structured differently, and I get that. But I just said that they're structured differently, great, but it facilitates my hypothesis in that the posterior annulus is very thin. So when you've got alternating headache, the asymmetrical distribution of pressure in the disc is on the other side, and you have headache on the other side. So this is a pattern of musculoskeletal misbehaviour that I identified in the early 1990s. And so you go about, I call it battle 1 and battle 2. So battle 1 is about correcting the rotation of C2, getting that C2-3 segment under control. Then battle 2 is identifying the segment which is being stressed by inferior oblique spasm, which is as a result of what's happening at 2-3, identifying the segment which is referring pain to the head and rendering that referral free. This is simple, not always easy, relies very heavily on skill palpation. So look, it's the Watson headache approach comes about as recognising this previously unrecognised pattern of musculoskeletal misbehaviour. Also, it's embedded in this process what is a series of techniques which can identify exactly which segment is referring pain to the head. And then, as I say, it's about your battle 1 and your battle 2. There's a clinical reasoning process around this. So, to summarise, it's recognising the pattern of misbehaviour and tackling that with a series of techniques, reproduction of headache, resolution of headache as one sustains a technique, and going about it in this clinical reasoning process, looking at it as 2 issues, B1 and B2. I call it battle 1 and battle 2. So that's it in a summary.
That's pretty interesting. So then you use those techniques to improve that unbalance that...
Yes. Yeah. If you, with episodic headache, if you win the battle at C2-3, you win the war. If inferior oblique stays quiet, it's not stressing. 0-1, 2-3.
Uh-huh.
So that's it. And many people, though, they go into reproduction, resolution of headache too early, and they keep on upsetting the C2-3 segment. No. You've got to be really patient here, particularly those patients whose headaches are swapping sides equally, 50-50. It's sometimes a bit like trying to control wet soap on wet glass. Really, really slippery. So there's a series of techniques for you targeting the C2-3 segment, and there are 7 techniques to identify which segment is referring pain to the head. And B2 is identifying the segment which is referring pain to the head and which technique at that segment reproduces headache most powerfully, and sustaining that technique for resolution.
Very interesting. Very interesting. So you try those techniques that, I don't know what type, they're like manipulations, they are like...
No, when you say manipulation...
Mobilizations.
Yes. There are no high velocity thrust techniques here. As a younger physiotherapist, I developed this irrational fear that I was going to hurt somebody or damage would be done. And I moved away from doing it. Now, the vertebral artery and all these considerations. So, and I know Roger Carey very well, and I interviewed Roger, and Roger has presented at our the online symposium a few years ago. So, yes, but anyway, I've developed this irrational fear, and I stopped doing them, and I haven't done them for 40 years or so. And I've been a physio for 47 years, all up now. So. But just since 1991, just with headache and migraine. So it is about sustaining the technique. It's not oscillating. So going in, and once again, I think some people go in too firmly, and it's really it's skill palpation, and it's listening. It's looking for feedback from the segment. It's a bit like having a dance, and I'm going to be a little bit genderish here, but I like to think of the as the segment being the male, and I follow that. So my thumb is the female, and you follow the lead of the male dancer, and you're looking for feedback here. Don't dictate what you want from the joint. You receive from the segment, and so it is very much on palpation, and one needs to look for the plane of greatest resistance, which would be the point of maximum, and the point you're most likely to get referral if you're going to get referral.
So I had some experience on myself because I have headaches as well. And like sometimes that's a
very, very expensive home visit. You want me to come and sort your headaches out?
That would be wonderful. So I have the alternating headaches, and I noticed like these days, I think it was last week, just pressing on the sternocleidomastoideo. I don't know how you say the name of the big muscle. So like if you press on it, I press on it, reproduce the headache, and then after a while it stopped. So when you're saying sustaining techniques, does that include like some trigger point desactivation? I don't know how you call it.
My goal is not doing trigger points. Now, when you're palpating C1 and the lateral arch of C1, you can get good bony contact over what I call the medial arch of C1, so closer to the midline. Yes, sure, you've got to try and navigate your way around the rectus posterior major and minor. So, potentially what you're doing is influencing some of the muscles there. No, I don't do trigger point therapy. Yeah, and I won't comment on that because I'm not skilled at doing that. And I understand people say, yes, you get reproduction resolution by doing something in the sternomastoid. I get that, but does it stay away? Does it keep recurring? And the goal, of course, with our patients is that they don't need to come back for treatment. So all of these techniques are aimed for good bony contact, and you can get out over the articular pillar of C2 easily, avoiding the muscles. A central PA on C3, yes, you could get on that without any significant soft tissue. And the lateral arch of C1, yep.
Okay. And
by the way, you said your headaches alternate, did you say?
They do, yeah.
Do you think your neck's involved?
Absolutely, 100%.
What would you know? You're only the patient. And this is another frustrating part of me, for me, because I'm sorry, patients aren't listened to. They know. They're an expert.
Yeah.
Anyway.
Yeah. They know best about their condition. So when you say about a sensitized brainstem, and I remember seeing something and you said that central sensitization can be resolved pretty quickly. So how you desensitize the brainstem? Because I think that's what we are talking about here.
Yes,
what is the
We are. Now, we know, as I said, there's widespread agreement that in the primary headache types, we are dealing with central sensitization. But of course, there are two types of central sensitization. There is centrally driven central sensitization. So something inherent within the central nervous system is leading to this. And what the finger is always pointed at, or is commonly pointed at, the diffuse Knox inhibitory control system. So you're descending inhibitory influences. Okay. But of course, central sensitization can be as a result of ongoing barrage of peripheral nociceptive information. Right? Now, the medical model of headache, there's an assumption that sensitization in primary headache is as a result of dysfunction of the descending inhibitory pathways. Now, it is an assumption. The jury is still out. The research is equivocal. When you look at the research, the conclusions are, it suggests this, and maybe this, and this possibly, there's nothing concrete around this. For every bit of research which suggests that it's a descending inhibitory pathway problem, there's another bit of research that says condition pain modulation is normal in migraine. And furthermore, when you look at condition pain modulation, if it's altered, is it because of increased facilitation or impairment of the, so it's a minefield. But Mariana, when you go in as manual therapists, when you go in and do a manual intervention with a centrally driven central sensitization, what happens? There's aggravation, there's temporal summation. The patient's pain gets worse. This just does not happen with headache. At worst, it doesn't change. Very, very, very rare does a headache get worse as one sustains the technique. As I said, 9% of the cases, you'll get resolution if you're doing the technique really well. So, that's how that's my assumption. As I said to you before, I think reproduction and resolution of typical head pain is the most powerful clinical tool we have of demonstrating cervical relevancy. And in terms of with the seminal study in my Ph.D. where I used a nociceptive blink reflex, people were saying, well, how do you know that you weren't activating the diffuse Knox inhibitory condition pain modulation? Well, when you look at the research very closely, or that paper very closely, the pain responses suggested that it was happening at spinal level, because pain responses in the head didn't change between an arm intervention and cervical intervention. I'm getting into the research a bit here. If you haven't read my paper, that probably wouldn't make sense, but the paper's there. But anyway, the research clearly shows that it's not psychological. And also too, reflexes don't lie in terms of placebo. Reflexes don't lie. They're not influenced by placebo. So I don't know what it is at the spinal level that's happening here. That would be someone else to do. I'm very much a clinical researcher. I don't know the exact effect, but I just sit back and I think, yep, so here we have reproduction and resolution, and that's good enough for me. Someone can take it on from that and look more closely at the underlying, the neurophysiology that's happening. But my research showed that it wasn't as a result of inhibitory pathways.
So you feel like, let me see if I understood it right. You're saying that is more peripheral, the mechanism of sensitization? Yeah.
In primary headache, in 90% of patients, I'm going to get reproduction and resolution of head pain.
Yeah. Okay.
And I'm targeting a peripheral input, cervical. And so, yeah. Now, do I help everyone I see? No. Probably 20% of people I see I don't help. This is anecdotal, so 80% of people are going to be improved significantly. Now, that 20%, it's not necessarily because it's not cervical, but sometimes what we have to offer people over 3 or 4 treatments, and this is how much I give myself to make a change in someone's headache, irrespective of the length of history. Sometimes what we have to offer people over a couple of weeks, 3 or 4 treatments, is not powerful enough to overcome what they're doing with their next 40 hours a week, 50 hours a week. That's the reality.
Mm-hmm. And so when you have the resolution after the reproduction of the symptoms, would that be considered you're desensitizing the brain stream?
Yes.
That's the, okay.
Yep. This is how the triptan, the medication works. The triptan medication, it aborts migraine by desensitizing the trigeminocervical complex. And here we have a manual cervical intervention replicating or mirroring the effect of the triptans, the heavy-duty anti-migraine medication. It also mirrors the great occipital nerve block. Research has shown that doing a great occipital nerve block ameliorates the nociceptive blink reflex. They measured the reflex, demonstrated sensitization, did a nerve block, great occipital nerve block, and then remeasured the blink reflex again and changed it significantly. So once again, a cervical intervention with a needle, we can do it with our thumbs.
That's awesome. Way cheaper, way easier.
Yep. And safer.
Yeah, safer for sure. Okay. And how about the results? Like when you get that resolution, do you have to see the person other times to keep working on it? Because you said that happens pretty quickly. Does the results last? Do the results last?
Look, the surveys show, once again, it's anecdotal. We haven't done any scientific, peer-reviewed stuff on this, but surveys show that 80% of people are improved at 12 months, still improved at 12 months. So we've had people come in to audit the notes and then ring people anonymously and find out sort of thing. So, no.
Do you keep seeing them?
Oh, look, there's a group of people where this musculoskeletal misbehaviour is going to keep recurring. So let's say, for example, I've got someone within 3 or 4 treatments, they say, Dean, well, it's amazing. I've been headache-free now for 4 weeks. So what do we do? And, well, on balance, the chances are this misbehaviour is going to want to try and recur at some point in time. It might not. But if it is, when? I don't know. It could be 3 months, 6 months, 12 months. So it can be really hard moving forward. And this is exactly the conversation I have with my patients. I don't want to over-treat you. I don't want to under-treat you either. It'd be great to keep the ball rolling without it costing you too much money and keeping you, we want to keep you free of this. So it can be, and some people choose to say, well, they choose, Dean, I'll stop, see how we go. Others will say, no, Dean, let's check it again in 4 weeks' time. And then 2 months' time. And in 3 months' time. And then, still headache-free, great. See you later, you ring me. But there are a group of people who are, I'm seeing roughly every 3 months or so because it just keeps on coming back. And that's the reality of life, unfortunately.
And then when you see your patients again, if they don't have headaches, do you still do the techniques as like a prevention?
I check C2, do all my palpation, and I really challenge it well by adding progressions to the techniques, there's some techniques that I can check that I do routinely, and yep, all great, fine. That's it, see you later. But if there's still something sitting there, if you feel as though there's been some deterioration, then you go in and do the same again.
So you prevent that.
Yep. And look, there is retraction, Mariana. Retraction is a powerful tool for C2-3. It's a powerful tool for C2-3. So for many people, they're able to correct the rotation of C2 by doing generalised retraction. And I won't go into retraction, but I break retraction up into generalised and localised retraction by blocking C3, etc. But that's for another time. But so there is a home exercise program, but it's very simple. They don't get 20 things from me to do apart from in lifestyle, posture, these sorts of things. Mm-hmm.
Yeah. Okay. Well, before we transition to our final questions, Dean, I know we talked a lot of information. Do you want to say anything else before transition? Anything that you want to add to everything we just said?
Ooh, Mariana, we've covered. No, I don't think so. Other than look, that's just the perspective, and I know. I mean, treating headache. It's just so people say, Dean, don't you get bored just treating headache and migraine and other conditions? I think, no way. The buzz you get when you change someone's life, and this for all of us, it's intoxicating. It's why we do what we do. But for me, there's always something extra special about changing someone's life, because headache is a tough gig. Migraine is a tough gig. I'm very careful to say I understand to a patient, because I can't. I'm fortunate enough I haven't had that. So, but I do say to people, look, I've spoken to over 10,000 people now in similar situations to you, and I get it's a tough gig. So look, Marianne, it's emotionally demanding. It is emotionally demanding. I invest heavily emotionally in my patients. And when I niched in headache and migraine, and my life turned around. I don't work anymore. This is not work. So it sounds a bit pathological, I think, but actually it probably defines me. Whereas, in 85, I was thinking of leaving physiotherapy. And I guess my advice for someone starting on physiotherapy, and you won't know necessarily when you're just starting out, but I think it's better to be, to look to becoming, to niche, if you find something you're really passionate about. But, people say, oh, Dean, you're really lucky. You found your passion. I said, well, yeah, but you know what? We're all passionate about making a difference. And if along the way, as you're working out where you want to go, you find something, wow, and there's, you think, oh, I'll focus on this. Because now there's an 80% chance that I'm going to help this person sitting in front of me, as opposed to before when I was trying to do everything. It was so frustrating. So for me, that would be a message there. And I just say I'm so blessed. I'm so lucky to be in this situation that I am, because it's just not work. So I'm getting on. I'm almost 70, and my thumbs and shoulders and occupational hazard. But so I'm only consulting a couple of days a week. But I don't want to stop consulting because I love it. I think the other thing about consulting, and I don't do it for this reason, but as a teacher, to be at the coalface, still consulting, gives me credibility. So I run courses, face-to-face courses, I've got an online course, et cetera, et cetera. So for me, though, the rest of my time is developing the teaching material, and I'm always learning. I'm still learning from my patients. It's as I say, it's been an amazing journey, and I'm a very, very, very lucky man.
That's incredible.
For me, my goal is, if before I die, a skilled examination of the upper neck becomes routine when investigating primary headache conditions, I will die a happy man. I'm not sure I'm going to get there because there is this resistance, I have to say, respectfully. There is this resistance from the medical model of headache, of the role of the neck. And that's just the reality. That's the way it is. So, Mariana, thank you very much.
Well, you are doing your part.
Yeah. Well, I can't do it on my own. We need an army. We need a team.
And Dean, if anyone wants to learn more about the topic, do you recommend any resource or anything that they can go to?
Oh, look, it's such a vast. What I do in my courses is to try and condense all the literature that's out there around headache, because you can go and read. There's no one article, or publication, or even a series of publications that's going to give you the picture. So my job as a teacher is to try and bring it all together and summarise it for you, because the diagnostic, the handbook for the diagnostic criteria is something like over 200 pages, and cervical headache, it's a paragraph at the back. And don't get me started on menstrual migraine. That's a topic for another time. I'll leave it at that. But my job is to it's not to bash the medical model either. It's just about to point out that the inadequacies of it. But I'm just the messenger here. There are other people saying doesn't quite meet the needs of clinicians. It was designed specifically, or initially, for research purposes, this classification system. And so if you're doing research around headache and you want it to be published, you have to adhere to the classification system, otherwise it won't get published anyway. So, a flawed classification system, particularly when it comes to cervical headache. But yes, Mariana, I'm conscious.
Okay. And if people want to find your courses,
watsonheadache.com.
Okay, perfect.
watsonheadache.com or dean@watsonheadache.com.
Okay, perfect. Well, thank you so much, Dean. We learned so much with you today, so I appreciate your time and sharing all your knowledge and expertise. And I have to thank Palmiro for connecting us. So, and it was great. It was a pleasure to have you.
Been a real pleasure, and thank you very much. Look forward to meeting again somewhere sometime soon.